Good morning. If everyone could please take their seats, we're going to begin. Good morning. Welcome to day 2 of the HCPCS public meetings for drugs, biologicals, and radiopharmaceuticals. My name is Felicia Eggleston. I'm the team leader for the Part B drug team here at CMS. So I'm just going to go over a few things here before we start our meeting. I want you to know that this meeting is being webcast via CMS. The CMS webcast is live and it begins as our meeting begins. By your attendance here today, you are giving consent to the use and distribution of your name, likeness, and voice during this meeting. You are also giving consent to the use and distribution of any personally identifiable information that you share on today. So we ask that you please do not disclose any personal health information. The webcast can be found in archives after the meeting on YouTube or the CMS Ustream website, and I believe it is housed there permanently. So some brief housekeeping items. So if you need to go to the restrooms, you go out of these doors to my left. You proceed down the hall to your right. You'll see the restrooms on the left as well as some telephones. If you need to go out to downstairs to the cafeteria or to the coffee stand, you proceed past the elevators on your right and go down the stairs and to your left, and you'll see our cafeteria. We have been asked to remind you that for security reasons, visitors may not enter any areas of the building other than our public areas, which is the lower and first floor lobbies, unless you're escorted by agency staff. If you need any assistance with arranging a taxi service today, please see the concierge in the lobby. CMS is a non-smoking campus. There is a smoking area outside at both of the gates to the entry to the campus. We'd like to ask that at this time you would please put all cell phones and BlackBerries on silent. I'd like to also ask that all speakers and anyone answering questions, please be sure to step up to a microphone so that everyone can hear. This includes outside participants as well as agency staff. For primary speakers, you'll stand here at this podium. 5-minute speakers and any other speakers, we'd like to ask that you would approach the microphone here in front of the stage. We'd like to ask for everyone's cooperation and sticking to our presentation times. 15-minute speakers, you know that you have up to 15 minutes. And then our 5-minute speakers, you have up to 5 minutes. I'll be keeping your time today via our time clock here to my right, your left. I have remote control back there. I click the button, 15 minutes, so 5 minutes on. For 15-minute speakers, we ask that you would just glance periodically. Once you get to 2 minutes, I'll gently whisper 2 minutes. That's your cue to wrap up. And if you've exhausted your time, I will stand behind you. But after you finish your presentation, if you glance at me, I'll let you know if there's a 5-minute speaker. If there is one, please just have a seat right behind me in these chairs, and we'll hear from the 5-minute speaker before we open up for questions. So I'd like to also let you know that no one can call on speakers or designate any unused time. Only I, your moderator, can call speakers. Time permitting, we may have a coffee break this morning. So at this time, I'd like to introduce Cindy Hake. She is the Deputy Director of CM's Division of DemiPost Policy and of the CMS National HCPCS Level 2 program. She will provide opening remarks and a brief description of the background and purpose of today's meeting. Cindy Hake.
Morning, everybody. How you doing? Thank you for coming. And so today is day 2 of our 3-day meeting this week for drugs, biologics, and radiopharmaceuticals. And so those of you who are still in town, if you wish to hang around and join us tomorrow as well, you're certainly welcome to do that. So this meeting here is part of an open process that builds in an opportunity for us to take feedback and to reconsider our coding decisions before we finalize them. And so this is part of the overall public component of our coding process. Came out of BIPA 2000. Originally in 2002, when we had our first public meeting, it pertained to DME only, but it didn't take long at all to recognize the value of these meetings to us, and we think to our customers as well, as we think that the quality of our decisions is better, and sometimes we do change our mind, which just confirms again the value of these meetings for all of us. So in 2005, we expanded this public hearing process to include all categories of applications for codes that come before us. Before the public meetings, CMS's HCPCS work group convenes to review all the applications and formulate the preliminary decisions that we published on our website and that you see in your agendas. And in addition to that, we provide Medicare payment decisions for DMEPOs, for drugs and biologics. That comes more in the form of an overview about the payment policy that Felicia will be reviewing with you, and it should be attached to your packets as well. You should know that the work group membership includes representatives of all government and non-government insurance sectors. So we have representatives of Medicare, Medicaid, the private insurance sector, VA, and DOD. We publish our preliminary decisions together with our rationale, and then via this process, we take input that either supports or refutes our preliminary decisions. And then after the meetings, the work group reconvenes and reconsiders each and every application before us, together with the input that we've received, either by you in person here or input in writing, as we formulate our final decisions. Between now and the time we publish final decisions, we will publish a summary of the public meetings that will look very much like the summaries that you have in your agendas today, but we'll add a few bullet points that we've captured of the key points made by our primary speakers. Final decisions then are released typically in the first week of November. We always hope it'll be by November 1st. And that comes out in several forms. We send individualized decision letters to each and every applicant. In addition to that, we publish in two formats. We publish our decisions in a spreadsheet format and also in a text format that gives the whole story, the topic of the application, the summary, the preliminary decision, the public meeting comments, and then the final decision. So that's kind of a nice narrative of the life story of every application in the cycle. So I want to thank you once again for traveling here to be with us today, for taking the time to offer your input. We take it very seriously. It means a lot to us, and I hope you enjoy the day.
Thank you for that overview, Cindy. Now, I would like to read a brief overview of Medicare's Part B drug payment. There's a more detailed description of the payment for Part B drugs attached to the end of your agenda. So, Medicare Part B pays for a limited number of prescription drugs. For the purpose of this discussion, the terms drugs will refer to both drugs and biologicals. Currently covered Medicare Part B drugs generally fall into three categories. The first is drugs furnished incident to a physician's service. The second is drugs administered via durable medical equipment. And then the third is drugs covered by specific statutory provisions. Medicare pays for some Part B drugs using the cost or prospective payment methodology, typically under a prospective payment system, such as the outpatient prospective payment system. Drugs are not paid for separately. Instead, payments for drugs that are furnished during an encounter are bundled or packaged with other services furnished during that encounter. However, most Part B drugs are not paid on a cost prospective payment basis and are paid for separately. Historically, there have been three approaches that have been used to determine payment amounts for this latter part of Part B drugs. So, prior to January 1st, 2004, payment for the majority of the Medicare Part B drugs was set at 95% of the average wholesale price, or AWP. Effective 2004, the Medicare Prescription Drug Improvement and Modernization Act of 2003 reduced the payment rate for most covered Part B drugs from 95% of the AWP to 85% of AWP. Effective 2005, the MMA required the implementation of a new pricing system based on a drug's average sales price. This approach is currently used to pay for the majority of Part B covered drugs. Effective January the 1st of 2017, infusion drugs administered through DME are paid using the ASP methodology. Now, there are some exceptions to the ASP pricing methodology, so there are certain drugs that are not paid using this methodology. Payment for these drugs use methodologies such as the AWP, which were in place before the MMA authorized the ASP methodology. This list includes vaccines, blood and blood products, and radiopharmaceuticals. So payment for Part B drugs is determined at the HCPCS billing code level. In order to facilitate appropriate payment, it may be necessary to create unique HCPCS Level 2 codes for certain products. So that we can implement coding and pricing changes promptly, CMS has used and will continue to use this internal process when appropriate for modifying and updating the HCPCS code set. Please be aware that internally generated code requests are not part of the HCPCS public meeting process. ASP payment determinations are made by the Division of Ambulatory Services and the Hospital and Ambulatory Policy Group within the Center for Medicare. DAS maintains an email box for inquiries related to ASP payment methodology. The email address is SEC, short for section, 303, ASP, as in average sales price, data at cms.hhs.gov. So now I'm going to introduce some other CMS HCPCS staff. Many of you have had the opportunity to speak with them either in person or by phone. They worked so hard to pull together all of the details necessary to get your public input on today. The first I'd like to introduce is Judy Wallace. Nathan Hellman, and Kimberly Combs Miller. These are your CMS HCPCS Workgroup meeting coordinators. So I'd also like to introduce Dr. Preeta Chidambaran. Dr. Preeta is our medical advisor to the CMS HCPCS Workgroup. I'd like to also take this time to thank Charles Hirsch and our people behind the booth here for handling all of our audio-visual needs on today. So now I'm going to describe how our meeting will proceed. Everyone should have received an agenda. If you have not received an agenda, there are copies still available out on the table. For each item on today's agenda, there is a written summary as well as CMS's preliminary coding decision within that agenda. The meeting will proceed one agenda item at a time until we have completed the agenda. We will hear a presentation from the registered primary speaker, if there is one, and any 5-minute speakers, if there is one. We like to ask that every speaker state who you represent, state your relationship to the applicant and to the manufacturer, declare in your oral presentation and in your written summary whether or not you have any financial involvement with the manufacturers or competitors of any items or services being discussed. This includes any payment, salary, or benefit provided to the speaker by the manufacturer. We'd like you to also state whether you agree or disagree with the preliminary decision, and when you summarize your comments, state your rationale for agreement or disagreement. After we've heard from all registered speakers, we will invite discussion and ask questions specifically related to that item. Now, we will begin. Agenda item number 1, application 17.20, request to establish a new level 2 HCPCS code to identify Photrexa or viscous Photrexa. Primary speaker is Dr. Raj Paul.
Good morning. Thank you for the opportunity to present here today. I'm Rajpal. I'm Chief Medical Officer for Avidro and a paid employee. I also do practice as a cornea specialist at C. Clearly Vision Group in the Washington, D.C. area. I perform corneal surgery, cataract surgery, and refractive surgery. I also do serve as the consultant for corneal diseases and surgery at the Walter Reed National Military Medical Center. In the next few minutes, I will be presenting my thoughts on why I disagree with the preliminary decision not to approve a new J-code for Photrexa. As background, the HCPCS work group recommended not to establish a new Level 2 HCPCS code to separately identify Photrexa because Photrexa was considered an integral part of the procedure, and payment for that service was thought to include payment for Photrexa if it's used. Omidria disagrees with this preliminary decision and asks that it be revised to create a J-code for Photrexa because, one, the drug is used more than 50% of the time in a physician's office, and a unique code is needed for separate billing and payment in that setting. Two, the work group has established J-codes in similar situations, and I'll share some examples of these shortly. Three, per guidance from the AMA, Photrexa is not paid as part of the corneal cross-linking procedure during which it is used. And four, a J-code for Photrexa is especially important since this drug is used for 2 orphan disease indications and is the only FDA-approved drug used to perform corneal cross-linking procedures. Thus, the HCPCS work group should issue a new J-code for the descriptor on the screen right now. So first, a little bit about keratoconus and corneal ectasia. At the bottom of the slide right now, you can see a cross-section of the normal eye. Think of the cornea, as most of you already likely know, as the lens of the eye that does most of the focusing, I should say the front lens of the eye. And perhaps the best analogy you can use is like a crystal on a watch. In keratoconus, this cornea is structurally weak, so it becomes progressively thinner and stretches. That leads to distortion as well as often scarring. This can lead to loss of functional vision, blindness, and the need for corneal transplantation. Keratoconus is generally diagnosed in the teenage years, whereas corneal ectasia generally affects a relatively older population, because this occurs after patients have had prior refractive surgery. So how does corneal cross-linking work? It uses a photosensitizer, such as riboflavin, combined with a UV light that causes the collagen fibers within the cornea to cross-link, creating a stiffer and stronger cornea. On the right-hand side of the slide, you can see the data that was submitted to the FDA from the clinical trials. The orange color towards the bottom indicates flattening, so the cornea is becoming more normalized, and that is what occurs when treatment is performed. The blue is the control group, the comparison group in which the cornea continues to steepen. This difference was statistically significantly different, and as you can see towards the bottom right, at 12 months, there was significant flattening of the patients who had treatment. This ultimately formed the basis for FDA approval for collagen cross-linking. So how is the surgery performed? On the right-hand side of this slide, you see Photrexa being instilled. This is done after the epithelium is removed from the central portion, the superficial portion of the cornea. The Photrexa is then instilled for 30 minutes. The cornea is then examined. Pachymetry, or corneal thickness, is measured. And then the UV light is irradiated when the cornea is in normal position. This continues for an additional 30 minutes. This procedure, as I mentioned earlier, is performed more than 50% of the time in an office setting, and certainly that's what we do within our group as well. This typically does not require the use of an operating room and typically does not require a systemic sedative. Even in the military, where as an institution there is certainly easy access to an operating room, this type of procedure is typically performed in the eye clinic in an office setting. So let's turn to examples I mentioned earlier of similarly situated products, Otiprio and Ameluz, and I'll share some details on these in just a few moments, for which the work group has granted or is in the process of granting a J-code. We also know that physicians can use a non-FDA approved compounded formulation of riboflavin, so that Photrexa is not the only drug that is used in collagen cross-linking. And thus a J-code is needed so physicians can bill and report Photrexa, which is separate and not paid within the procedure. Chronologically, I think it's important to understand how this process has gotten us so far to this date. In January of 2016, the AMA implemented CPT code 0402T. This is described as collagen cross-linking of the cornea, including removal of the corneal epithelium and intraoperative pachymetry when performed. FDA approval of collagen cross-linking, however, did not occur until April of 2016. And then since September of 2016, Photrexa has become available. We now know that physicians have been billing for the procedure with the new CPT code and for Photrexa with the miscellaneous drug code. So again, turning to the examples, Otiprio, which is used for tympanostomy, has been approved with a J-code after initially being denied for the same reason as Photrexa has been denied. After hearing about the site of service and that it is primarily used in a physician's office, the work group revised the decision and created a code. CMS has granted or proposes to grant J-codes for other drugs that have been used in photodynamic procedures. Ameluz has been given a preliminary decision to grant a J-code effective January 2018, and I believe was on the agenda, so the work group heard about the details of this yesterday, and similarly is a two-step process. In ophthalmology specifically, Visudyne is a similar process which is used exclusively with ocular phototherapy and has a J-code and is paid separately. So like these procedures that utilize drugs that have been granted J-codes, collagen cross-linking is also a multi-step process. It involves a photosensitizer, a drug, and then the application of a specialized light source. Turning to the CPT code, I'm going to read to you the guidance on 0402T. This new treatment often requires the removal of the epithelium and or the introduction of agents to increase the permeability of the epithelium to the UVA light, and is included in code 0402T. Topical anesthesia is the preferred method of anesthesia and is administered by the surgeon performing collagen cross-linking and is not separately reported. This guidance clearly identifies items that are not to be reported separately. For example, removal of the epithelium, as well as use of topical anesthesia drops. However, Photrexa is specifically not listed among those. Thus, CPT code 0402T does not include payment for Photrexa. And again, as I mentioned earlier, we know that physicians have other options. They are using compounded riboflavin, and we also know that there are multiple new drugs in development that will act as photosensitizers besides Photrexa. So thus, again, a unique J-code for Photrexa will enable physicians to bill accurately for this new drug. You should have received a letter of support from the National Keratoconus Foundation that I would like to just mention briefly. This letter is in support of the J-code. The National Keratoconus Foundation is the world's largest organization representing patients with keratoconus. And they specify in the letter that their primary concern without having a J-code is the possible lack of access for patients to be able to undergo collagen cross-linking because doctors will not have a proper methodology to be able to be reimbursed for the use of the drug. So in summary, again, I would like to reiterate that we disagree with the premise of the decision, the preliminary decision, to not grant a J-code based on Photrexa being integral to the part of the procedure and the payment for the service being included in the payment of the procedure. Omidria disagrees with this decision and asks respectfully that it be revised to create a J-code for Photrexa because, one, the drug is used over 50% of the time in a physician's office, and a unique code is needed for separate billing and payment in that setting. Two, the work group has established J-codes in similar situations, and I've shared some examples of those. Three, per guidance from the American Medical Association, Photrexa is not paid as part of the corneal cross-linking procedure during which it is used. And finally, four, a J-code for Photrexa is important, especially since this drug is used for 2 orphan disease indications and is the only FDA-approved drug used to perform corneal cross-linking procedures. As a result, we ask that the decision be revised and that the following new code be created. Riboflavin 5-phosphate with or without dextran, ophthalmic solution, FDA-approved final product, non-compounded, up to 2 3-milliliter syringes, single patient use. Thank you for your time, and I'll be here happy to answer any questions.
I'd like to call Stuart Langbein.
Good morning. My name is Stuart Langbein. I'm outside counsel to Avidro and otherwise have no financial relationships to report. I'm here because I want to express my disagreement with the preliminary decision of the work group, and that the disagreement is based on 2 points. The first is that this is a physician office drug that needs to be able to have the capacity to be billed separately. Second, the payment for the cross-linking procedure does not include payment for the drug, and I want to amplify some of the things that the primary speaker said in this regard. With regard to physician services, sometimes we look at the preliminary decisions and we see the language when a code's not proposed to be granted about the drug being integral to a procedure, and oftentimes that seems to send a signal that perhaps the work group doesn't believe that the drug is used in the physician office setting. And I think you heard from the primary speaker and just wanted to amplify that this is done 50% of the time or perhaps more in the physician office setting. So if that was part of the basis for the preliminary decision not to grant a J code, we would respectfully ask you to consider the physician office setting use of the product. And the fact is that as I'm sure you're aware, there are many drugs that are used as part of a procedure in a physician office setting that actually do have separate J codes. One example that comes to my mind are the pharmacologic stress agents. When you have a patient receiving a stress test in the office and they can't use a treadmill and they need to have pharmacologically induced levels of stress, they get a drug, and there are a couple of pharmacologic stress agents that are necessarily used as part of the pharm stress procedure, and they have separate J codes and are billed separately. So we're looking for Photrexa to have a similar treatment as those products. Another thing I wanted to highlight is the Otiprio example, because just last year, for this non-injectable drug, it seemed like it took a very similar course to Photrexa. Last year, the preliminary decision was not to grant a code because really for the very same reasons, integral to a procedure and paid as part of the code, of the underlying procedure. When we look at the CMS summary of the work group of the public meeting, it said that the primary speaker talked about the need to report the use of the drug when performed in the physician office setting, and the end result was the preliminary decision was changed to grant a J code for Otiprio. And we think this is a very similar situation to that as far as a drug that's used as part of a procedure in the physician office setting, and likewise should get a J code. The other point and last point I wanted to address is the notion is that the procedure payment here, the cross-linking procedure, does not include payment for the drug. The primary speaker mentioned the AMA guidance, and I just wanted to go into a little bit more detail. When CPT code 0402T was established in 2016, the AMA issued guidance in the CPT Changes 2016 book, and they talked about the photosensitizers that are used and other items and services that are part of the procedure, including removal of the epithelium. And in that guidance, the AMA was very specific about certain items should not be reported separately. So they talked about the removal of the epithelium and the topical anesthetic agents, and they said those products cannot be reported separately. So they knew what they were doing and what they wanted to not be reported separately. And Photrexa and the photosensitizers were not on that list. So we disagree with the preliminary decision statement that payment for the cross-linking procedure includes payment for the drug, because we don't think that's consistent with the guidance of the AMA on this CPT code. And I think you also have a letter from the Cornea Society, a physician specialty group, who of course is influential in the interpretation of the AMA guidance. And the Cornea Society letter also indicates that photosensitizers should be reported separately. So we encourage you to consider that letter as well. So for these reasons, we'd ask that you revise the decision not to create a code and instead create a J-code for Photrexa effective January 1, 2018. Thank you.
Happy to take any questions if there are any.
Could you go, Dr. Rajpal, thank you very much.
Sure.
Could you go back and explain a little bit about the drops and like if there's a minimum amount that's used and how the without and with dextran, just a little bit more information for us to work with? Thanks.
Sure. So Photrexa viscous, which is the version with dextran, is used initially after the epithelium is removed. It's applied every 2 minutes for 30 minutes. The cornea is then evaluated at a microscope to make sure that we can see the cornea has riboflavin within it, that is saturated in essence. If we see that, and that's determined by looking for something that we call flare within the eye, we then also measure the corneal thickness. If it's greater than 400 microns, the UV light is initiated. If it's thinner than 400 microns, then the formulation of riboflavin called Photrexa by itself is used. Photrexa is hypotonic, so it actually swells the cornea a little bit. And that's instilled until the cornea becomes 400 microns. And then after that, the UV light is instilled. And then through that entire process of 30 minutes of the UV light, the Photrexa viscous is continued.
Is there like a minimum amount that would be used with all patients or?
Well, since it's applied every 2 minutes, it's less than the amount that's in the vial, in the syringe. So because the drop is not always consistent and some of it runs off, I can't tell you the exact amount that's used, but it's less than the syringe.
Are there ever times when you have to open another package?
That would be extremely unlikely because, again, the syringe has enough volume to be able to have more than enough drops for that 30 minutes. Okay.
Can I comment?
Can you comment?
Okay, thanks. Yeah, John McInnes here. So I'm an ophthalmologist and a CMS medical officer. And what I want to talk about is really the payment policy, because we reviewed the payment policy for this procedure, both in the physician office setting, the ambulatory surgery center setting, and the hospital outpatient setting. And so I just want to, some of the, I understand, how you, the sources that you used and the arguments you're making, but a couple things we can sort of dispense with. We know all about physician office use of this procedure. That's going to be the primary site. So we don't have to talk about that as a basis for not granting the J-code. So the majority of cases will most likely be done, because this is ophthalmology and it's non-invasive, in the physician office, or at least in ASC. So that's one point. The other point is that the AMA guidance really isn't relevant in this case. So what you have is kind of the typical descriptor that you have where, the AMA has made the point that some of the steps that are part of this procedure shouldn't be separately billed. So there's a separate code for removing the corneal epithelium. And just to make sure coders don't get confused, they make the point that you don't code a separate procedure for removing the corneal epithelium and then the corneal cross-linking. That's part of this procedure. Codes typically don't list all the items and supplies that are included or not included in the procedure, number one. So the absence of that really doesn't provide any information. I guess the more important point is that the American Medical Association doesn't make CMS payment policy. CMS does. And so for this procedure, the drops really are integral to the procedure. The only use for the drops is to accomplish the procedure, and the procedure cannot be done without the drops. So the payment policy is that there's a payment for the procedure, and it includes all the items and supplies that are required to accomplish the procedure. That includes the riboflavin. So that's the policy. I can answer questions about that, but I just want to be clear about that. That's why there, at least from CMS and the physician fee schedule payment system and the hospital outpatient and ASC, there doesn't seem to be a programmatic need for a separate code, because in the physician office that would be a practice expense that would be part of the payment that would go to the physician. And the same with the ambulatory surgery center facility payment and the HOPD facility payment. That would be all part of that facility payment that would go to the facility. That would include the cost of the eye drops.
If I could comment on that, a couple of things. One is, first of all, we don't know if the payment for 0402T includes the payment for the photosensitizer, because, as you know, Medicare doesn't set payments for Category 3 codes. From a Medicare standpoint, we don't know, and certainly we're looking at not just ensuring payment in Medicare, but ensuring payment and the ability to report and be paid for a drug in other settings too. So there may be the Medicare payment policy, but this is about coding that is used for commercial payers in addition to Medicare. I'd also point out, I looked at the Otiprio video from the discussion last year, and there the tympanoscopy procedure actually has a CPT code, a Category 1 CPT code, and I think the presenter there was able to look at the practice expense input files and see that there was no drug listed in how the Medicare physician fee schedule constructs payment for that CPT code. So I think there's plenty of reason to believe that the payment for the procedure will not include the payment for the drug, and that may have tipped the scales for Otiprio to change it from a preliminary no to an affirmative yes.
Well, but okay, that's fine. But the thing with this procedure is that it's new. So we'll be instructing contractors to base contractor pricing on including the drug as a supply in the procedure. And then when it goes through RUC and when CMS, when this goes to a Category 1 code, it'll be priced accordingly. So there's not really, you really can't say at this point that there's been a decision not to include the eye drops in the cost of the procedure, because that issue hasn't been addressed except for by me today. I'm telling you that is in fact the policy.
And I know your word is good, John, but I also think that we are trying to figure out coding for the not just Medicare, but for the commercial setting too. And I don't think either one of us could talk about what private insurers will do with 0402T. And right now, people are billing a separate code. They're billing a miscellaneous code for the drug on the commercial side. And I don't know for sure, and maybe people at the company do know, if the commercial payers are paying separately for the drug and 0402T. And so we need a code, we need a J code to be able to ensure that commercial payers can make their own determination as to how they're going to treat 0402T and the photosensitizer.
Okay, I just want to reiterate what I said this morning, that we do have all government and non-government insurers on the panel. Everybody's input is taken into consideration. We have representatives here with us today, so we're hearing that, Stuart. And in addition, I don't know if I heard you suggesting that the same code ought to be used by all insurers, even if they don't pay, even if one insurance sector wouldn't separately pay for a code, but that's not necessarily true. Non-Medicare insurers in particular can and do use NDC codes. State Medicaid agencies can use NDC codes. So I just wanted to clarify that point. All that's required is that there's a national set of codes for insurers to choose from in assigning to products, but there is no requirement that they all treat the same products the same way.
Okay, thank you very much.
Agenda item number 2, application 17.58, repeat request to establish a new level 2 HCPCS code to identify Omidria. Primary speaker is Mr. Brian Curry.
Thank you very much. I'm Brian Curie, presenting on behalf of Omeris. I serve as regulatory counsel to Omeris, but otherwise have no financial interest. We appreciate the opportunity to present to the HCPCS work group and appreciate the consideration of this issue and working with CMS over the past 2 to 3 years on coding for Omidria. I'm going to provide a brief clinical overview, and then the 5-minute speaker will be Dr. Larry Patterson, who will speak in more detail about the clinical issue of Omidria. At the outset, we'd like to make clear that we respectfully disagree with the preliminary recommendation of the HCPCS work group that there is not a program operating need for a unique J-code for either Medicare, Medicaid, or commercial payers, and we'll go through in detail what the experience has been to date from FDA approval and what we're hearing in particular from commercial payers about coding for this product and why we think it warrants a unique J-code at this time. In terms of background, Omidria is the only FDA-approved drug for treatment during cataract and lens replacement procedure. Cataract's one of the leading causes of blindness. It's a significant issue for both the Medicare population, but also for commercial insurers. Omidria is administered by an intracameral injection during cataract surgery. It's typically performed in either the hospital outpatient or ambulatory surgical center, and Omidria is a combination of phenylephrine and ketorolac, and it's the only product approved by the FDA. They're all alternatives, which are unregulated compounded products. Omidria was approved by the FDA in 2015, and Omeris worked with the Center for Medicare and received pass-through payment in 2015, and with that was assigned a C code, which has been very important for use in the Medicare program, but as we'll hear, there continues to be an issue for commercial and Medicaid patients for a unique J code, and our application has requested a unique J code to be assigned for the injection of phenylephrine and ketorolac. In terms of looking at cataract surgery for the patient mix, we think it's important to note that while a large percent of patients are in the Medicare population, roughly a majority of the patients are outside of the traditional Medicare fee-for-service system, where Omidria is currently on the pass-through list, but after this year will be packaged as part of the surgical procedure. In particular, there's about 25% of the uses with commercial payers, 20 or so percent with Medicare Advantage plans, and then some usage with Medicaid. And we've heard in particular from the commercial insurers that either that they cannot use the C code or they would like to use a J code, and as we'll hear, the product is being separately billed and paid under the not otherwise classified code. As set out in the application materials, Omeris has been working for the past 3 years with providers to deal with claims processing and billing issues due to the lack of a unique J-code. We think that the experience shows that the product is separately paid by commercial insurers, and those commercial insurers are seeking a J-code, which would allow them to track utilization of this product. We're going to go through the types of payment and coding issues that have occurred over the past 2 years. They roughly fall into 2 categories. The first category is payers who have said they cannot or will not process the existing C code, and the second category is payers who are requiring the product to be billed under not otherwise classified J code. In both cases, providers are experiencing payment denials or significant claims processing issues. Initially, we saw with the C code when it came out in 2015 that a large number of private payers were informing providers that they could not process the C code. This was leading to claims processing errors. We heard from a number of the Blues plans in particular that they would not or could not process the C code, and as a result, providers have been billing the not otherwise classified code. As mentioned earlier, this is a repeat application. Omeris presented similar information at past public meetings, and we think that the evidence has only grown that the product continues to be separately payable, and in particular, the commercial insurers are requiring the use of a J code. The current situation, as we'll hear from Dr. Patterson, who will speak on behalf of physicians using the product, is that a large number of the commercial insurers are informing providers that they cannot process the C9447 code, and instead they're requiring the use of the J3490 in combination with an NDC code. We understand and appreciate that many new drugs and biologics bill the not otherwise classified code following FDA approval, but as we've heard with a number of the products on the agenda for yesterday and today, that typically most products that are separately payable migrate from the not otherwise classified code to the specific unique J code. And this is important both for the providers to be able to bill for the products and for the payers to be able to track utilization specifically of these products. Where Omeris has been, unlike other products that are separately paid, is that they have been using the not otherwise classified code for close to 3 years now, and they have had significant claims processing issues. A lot of this has led to administrative burdensome appeals, paper claims submissions, requiring the providers to follow up directly with the commercial payers to get the product paid for. And what we've heard from the providers and what we understand from the payers is that similar to other separately payable drugs, that a unique J code would greatly facilitate the claims processing and would allow for the payers to track the product and understand the utilization of the product. So in summary, we thank the HCPCS work groups for its ongoing review of this issue. We believe, as the application sets out, that Omidria does warrant a separate unique J code for the injection of phenylephrine and ketorolac, and we think that the primary program operating need is not with the Medicare program, but it is with the commercial insurers who are paying for the product separately today under a J code. I'm happy to take any questions after Dr. Patterson's presentation. Thank you.
Dr. Larry Patterson.
Good morning. My name is Larry Patterson. I'm from rural East Tennessee. Has been in private practice for 28 years. I'm the Government Relations Director for the Outpatient Ophthalmic Surgery Society, also known as OOS. And for the last 10 years, I've been on the American Society of Cataract and Refractive Surgery Government Relations Committee. I wanted to also address the need for this unique J-code for Omidria, and I have received compensation from the Omeris Corporation for both clinical consulting and preparation of these remarks. Omidria is the only FDA-approved product used as an injection during cataract surgery and other similar procedures that prevents meiosis. Meiosis is just a name that means the pupil gets smaller. It also, interestingly, reduces patients' postoperative pain. We didn't realize that was a big issue until the product came out, and it turns out people have a lot less pain with it. Omidria inhibits inflammation and thusly reducing the tendency for the pupil to get small during cataract surgery. And because the pupil is this viewing portal for conducting the procedure, Omidria optimizes that view during cataract surgery. And unfortunately, because Omidria does not have a unique J-code, there are a lot of claims processing payment problems that have just been mentioned. As an ophthalmic surgeon who performs about 25 cataract surgery procedures each week, I want to talk to you just a moment about the properties of the drug, both as labeled and also some of the things we've noticed since it's been approved. When the pupil constricts during cataract surgery, and say a typical pupil is 6, 7, 8 millimeters, when it constricts during cataract surgery, and they all constrict a little bit due to this inflammation and just the trauma of the surgery, our field of view gets smaller because basically all of the work we're doing is back behind the pupil. And even if it goes as small as just a couple of millimeters smaller, we have a dramatically reduced field of view. And what happens is we start having less ability to remove the cataract, lens fragments, placement of the new lens. We've just got this reduced field of view, and unfortunately, that's been shown over and over. The smaller the pupil, the increased risk of complications, posterior capsular rupture, vitreous loss, dislocated implants, trauma to the iris itself. So we've known this, and since Omidria has been approved and been used, there have been at least 3 studies I'm familiar with that have shown both the reduced risk of damage to the eye using this product, as well as reduced risk of pupil expansion devices, which are problematic in and of themselves. And my concern is just for patient access to this therapy. Many commercial payers, as has been mentioned, pay separately for Omidria, and they'll often require a J-code for billing, and this lack just creates a lot of burden on our staff as far as time and administrative costs. We do appreciate the C-code, which allowed the product to be paid separately by Medicare, but many people have primary or secondary coverage through commercial payers, and they're just not processing this code uniformly. They're rejected, need to be submitted again, and often on paper. Paper submissions are really burdensome on the staff. Many of us, in fact, pretty much everyone, has some sort of electronic system now to be in compliance with the law, and this additional cost of processing time and delay in payments have just caused a lot of our members to not use the product at all because they just can't afford to because of this, and obviously this limits patients' access to the therapy. In speaking with some of our members, both ASCRS and OOS, there's substantial agreement that these rejections and denials presents a substantial burden. These are affecting patient care, the ability of commercial and state Medicaid plans to even process the C-code, and as a result, a lot of surgeons are turning to off-label uses of the similar drugs, and there's some real problems doing that. They may not have the exact same active ingredients that have been proven to work in Omidria, but there's just some real serious regulatory and safety and legal concerns with doing with injecting compounded drugs into the eye in these situations. So in summary, a unique code would really help us in reducing these processing and payment issues, regardless of their insurance type, allowing us to use the best product for our patient without the administrative hassles associated as it now stands. Thank you.
I have a question. John McInnes, CMS Medical Officer. I just want to make sure I understand this, and I think I do based on your presentation, and then I'd like to offer a little bit of context from Medicare. The third bullet says over the past years, lack of a J code has led to claim processing delays and denials for patients insured by Medicare. That's sort of, has the C code instead of a J code affected claims processing for Omidria with Medicare beneficiaries?
What we've seen with the C code in the Medicare beneficiaries, and this could be both Medicare or Medicare Advantage, is particularly in the first few years where it was on pass-through for patients that had secondary supplemental insurance, there were issues with processing the C code, and that was presented at the last HCPCS meeting as a basis for getting the J code. I think there's some of those issues that persist in 2017, but the real focus and need at this point and looking ahead for 2018 is with the commercial plans and Medicaid, who are requiring the J3490 to be billed today.
Okay, so it's really the private insurance that beneficiaries have.
Yes, I think the secondary payer issue is really sort of a historic issue that the company had requested the code for in the past to address, and it is still an issue in 2017. But for 2018, the primary operating need will be with the commercial payers who are using the 3490 code.
Okay, so just from Medicare, sort of what we did with this in the original request and our payment policy, back in 2016, and this is really kind of supplemental to your chief complaint, which is private insurance claims aren't being paid timely. We did based on some work we were doing at the Innovation Center, on physician office cataract surgery and bilateral simultaneous cataract surgery, we did a comment solicitation thinking, well, maybe the technology's evolved and physicians are ready to do this. The comments came back that we were overwhelmingly negative, extremely negative. There were meetings afterwards say, you're crazy, Medicare, we can't do, no responsible surgeon would ever do these surgeries in a physician office. So from that point, we sort of stuck with our thought that, the C code works for purposes of pass-through both in the ambulatory surgery center and the hospital outpatient department. So no J code from a Medicare programmatic need. And I understand, so you're not really contesting that. The other thing is there has been a final policy determination that Omidria will be packaged into the procedure. So for Medicare, beginning in 2018, there won't be separate payments, so a separate code, a drug code for separate payment won't be necessary in 2018. So that's a little bit of the kind of the Medicare and perspective on that.
Thank you. That's helpful, and that's consistent with what we've seen in the application. We said, less than 5% use has been in physician office. Maybe Dr. Patterson could speak to that, but that's what we've seen, and the issue really has been either with the commercial Medicare Advantage plans or the commercial plans where they are requiring the use of the 3490 code, and in some cases the J code plus an NDC.
Yeah, there are, as you know, very, very few surgeons doing cataract surgery in the office setting, and that's another controversy altogether, but I don't think I would think the people who are doing it in an office setting are probably, for payment reasons, not using it at all. But I don't know how they would even be able to do it in the office setting.
Yeah, I just offer that with the first presentation. That was, a big part of the rationale for, why do you? Because drugs will have get a C code when they go through pass-through, and then the question is if there's going to be physician office use. Those claims don't use the C code, so there's the programmatic need for the J code, and in this case, we really don't have that. But the Medicare and the private insurance is a separate issue.
Thank you.
Thank you both. Mr. Carey, I have a question for you. So you've made statements and written that that private insurers are requiring use of a J code or use of a J code NDC combination. Are there policies that you can point us to? You mentioned specific insurers. Are these the
Sure,
ones, Blue
yeah.
Cross Illinois?
Yeah, in our application, and then the company submitted a supplemental comment letter yesterday, includes some specific examples from the commercial insurers, and would be happy to supplement that after the meeting. The company has received emails and communications from particular payers regarding the use of a J code, and or individual providers have also heard similar information.
Because we do hear from folks here and there that J codes are being billed or miscellaneous codes are being billed and they're being paid, but that doesn't necessarily mean that that was an assignment made by the insurer. So I just want to separate and find out if
and
we're
we
actually talking about policy.
Absolutely, and we can submit that after the meeting as a follow-up. Thank you very much.
Thank you.
Agenda item number 3, application number 17.46, request to establish a new level 2 HCPCS code to identify Optiray Ultrajet. And application number 17.67, request to establish a new level 2 HCPCS code to identify the Optiray Ultrajet pre-filled syringe with radiofrequency identification technology. There are no speakers for these items. Are there any questions or comments? Agenda item number 4, application number 17.4, request to revise existing level 2 HCPCS code J7328. There is no primary speaker for this item. We do have a 5-minute speaker, Mr. Michael Daly.
Good morning. I know a lot of us will be in disagreement here, but one thing we're all in agreement. I want to thank you, the HCPCS coding group, for all your hard work and diligence over the years. You certainly do a very judicious and a hard-fought battle when we're all on one side of the speaker and you're on the other ones to protect the integrity of the coding system. With that said, my name is Michael Daly. I'm the former medical director for the first hyaluronic acid to be approved in the U.S. called Hyalgan. I am presently president and CEO of OrthoGenerics. OrthoGenerics was founded on the mantra of providing quality, safe products to the healthcare system at reduced cost and better patient access. I would also offer that this is a billion-dollar decision that you're making now because it can set precedent. Medicare has paid approximately $300 million for this class of products, intra-articular hyaluronic acid, every year. And so setting the precedent for how coding is done is an extremely important issue. But with that said, Medicare also engaged AHRQ to do a comprehensive treatment for the treatment of chronic osteoarthritis knee pain. That was published in 2015. And AHRQ's meta-analysis published then said that intra-articular injections are amongst the most efficacious, 2 to 3 times more efficacious than the standard of care oral medications. So money is well spent, but how can we make it more efficient? And I think that the HCPCS coding preliminary decision to modify descriptor 2018 is appropriate. But it does 2 things. One, it acknowledges that the company recognizes that Gelson 3 qualifies for a different descriptor within the coding system as well. And so with that said, CMS and the HCPCS code adopted a convention many years ago, which all the manufacturers have embraced, which uses the branded name of the product to identify the individual products that are on the market. The general description of that's in the HCPCS code, or Hyalgan or derivative, applies to all 11 products that are approved on the product. So the only differentiation that tells you between the J code and what the descriptor is the branded name. Accordingly, the applicant's rebranding without making a suitable application is inappropriate. And it leads to confusion and potentially sets up a precedent where any company can change the branded name without any limitations and then potentially change the reimbursement code. This is important because the reimbursement code, the average selling price of these products, vary tenfold. Presently, the ASP for the lowest price is $82.33 per syringe. The highest price is $844.88. So therefore, by doing this brand and switching with the different codes, it's going to be rather important to be very, very on a steady course to maintain this convention that HCPCS code has done. So in early 2016 until January 1st of 2018, when the code can be changed, I would submit that Gelson 3 is not an appropriate for reimbursement under J7328. And although it's not the purview of this committee, I would also add that it could be considered a false claims act by continuing to make these applications under that reimbursement code. Therefore, I would submit that the appropriate action would be to require the applicants that have already acknowledged the fact that Gelson 3 is not appropriate into the code by asking for its switching, that they require the applicants to remove all materials referencing the use of J7328 for the reimbursement of Gelson 3, and until January 1st of 2018, as a miscellaneous code, J code J3490, be used to reimburse that product. The integrity of the coding system is fundamental to maintain the appropriate billing and the downward stream in terms of appropriate reimbursement. Thank you.
Dr. Daly, always a pleasure to see you. Thank you very much.
Thank you.
So do I have this right? Are you saying that you're in agreement with including Gelson 3 in the code, but that ought to only be reported after January 1st, 2018?
That's correct. Until now, they should be using the miscellaneous code, which is, I think, an acknowledgement within their very application saying that Gelson 3 is not in the descriptor. And the descriptors for these reimbursement codes are the differentiator between these products. It potentially leads to a great overpayment if you start putting descriptors or changing branding names, which is a subject matter of one of the other applications as well.
We'll take that into consideration. Thank you very much.
Thank you.
Agenda item number 5, application 17.38, request to discontinue existing level 2 HCPCS code J7321 and replace it with 2 new codes, one code to identify Hyalgan and the other code to identify Supartz. Our speaker is Ms. Carolyn Kong.
Thank you so much, Felicia, and good morning to the HCPCS work group. My name is Carolyn Kong, and I'm a paid employee of Fidia Pharma USA, and I serve as the Chief Business and Development Officer. I am here this morning to provide Fidia Pharma US's response to the HCPCS work group's preliminary decision to maintain the existing code J7321 for both Hyalgan and Supartz. Fidia Pharma US respectfully disagrees with the preliminary decision and requests that the HCPCS work group reconsider their decision to maintain the current code J7321 and to permit the establishment of separate J codes for Hyalgan and Supartz. To provide some background, Hyalgan is the first injectable hyaluronic acid HA Visco supplement that was approved by the FDA in May 1997. It is indicated for knee pain due to osteoarthritis in patients who fail conservative therapy or simple analgesics. It is the most studied HA for clinical safety, efficacy, and biological activity, with over 100 clinical studies in over 15,000 patients. Unlike the other HAs, each of which have their own unique J code, Hyalgan and Supartz are both assigned to the same J code, J7321. Today, we would like to present our rationale for our request for a unique J code for Hyalgan. First, we believe that the current code does not adequately differentiate between the two products. Hyalgan is pharmacologically and therapeutically different than Supartz. As a result, there is a significant therapeutic distinction between the two products, and these two products do operate differently. In addition, by sharing the J code, we believe that patients are being denied access. There is also difficulty in tracking adverse events and properly characterizing each of the product profiles. This is important given that Hyalgan and Supartz have significant utilization in the marketplace, as demonstrated by claims data. Now we would like to review in more detail each of these points. Let us begin by looking at the pharmacologic profiles of each product. When we look at Hyalgan and Supartz, we see that there are significant differences that are typically seen in HA products that have their own J code. For instance, they each have very different molecular weights. They also have different volumes per administered injection. There are differences in dosing per injection, such that over the course of a recommended treatment regimen, there is a difference in the total dose administered to the patient. Thus, Hyalgan is pharmacologically distinct from the other HAs on the market and is not interchangeable with Supartz. Oops. There we go. Furthermore, we see that there are operational differences between the two products. Hyalgan has superior biomechanical lubricating properties compared to Supartz due to its lower coefficient of friction. Hyalgan has also been demonstrated to have significantly improved medical outcomes compared to other HAs, including Supartz. With the decades of research and utilization of Hyalgan, we can clearly state that Hyalgan is both pharmacologically unique and in terms of having superior disease-modifying activity in preclinical testing, and as well as having different molecular weights, different dosing per injection, and as stated as earlier, different total dose per treatment regimen. In addition, Hyalgan is therapeutically unique in that it is the only approved intra-articular HA that has clinical data compared to NSAIDs in its label. It is also the only HA with long-term 30-month safety data and efficacy data of repeat treatments in its label. It is the only HA with cost-effectiveness data for almost 4 years, demonstrating lower total knee replacement rates compared to rates seen in the literature. Finally, Hyalgan has been shown to have a lower adverse event rate in a published study compared to Adant, which is a product molecularly similar to Supartz. Another key reason why we believe that Hyalgan should receive a unique J code is the fact that patients are being denied access to this important treatment option. By sharing the same J code as Supartz, there is limited access to Medicare Advantage reimbursement, as well as limited access to private payer plans. as Hyalgan is excluded from several private payer formularies. Payers need to be able to separately identify HA products in their claim forms. With the inability to do this, some private payers will not cover these two HA products, Hyalgan and Supartz. Roy Smith, our Director of Managed Care, will be going over this in more detail, but for now, we want to highlight that this is a key issue. From an operational standpoint, by sharing the same J-code, payers cannot differentiate dosing differences in their systems, which is a programmatic concern given the different dosing of the two products. And finally, by sharing the same J-code, there is no transparency for pharmacovigilance reporting. This last point on the difficulty of tracking adverse events merits some focus. As a pharmacist by training, this is an area of concern. By sharing the same J-code, it makes it impossible for payers and healthcare professionals to identify which product is attributed to which adverse event. Having separate J-codes would greatly enhance the ability to track and report adverse events. Proper reporting would help better characterize the profile of each product and see that the appropriate follow-up and measures are taken to ensure the safety of patients. This last point is important given the significant utilization of these products. Shown here are the IMS data on the number of ERA claims for the intra-articular HA class over a course of a year. You can see here that there are over 1 million claims. And of these, Hyalgan and Supartz constitute greater than 30% of these claims. This is truly a significant number. The sheer utilization of these HAs justifies having a separate code for each of these products. In summary, we have shown that Hyalgan is unique compared to Supartz. Being both pharmacologically and therapeutically different, having different dosing per administration, and operating differently. Thus, Hyalgan satisfies the criteria set forth by the HCPCS coding policy for establishment of a new code. By having a unique Level 2 HCPCS code, it will give more patients access by allowing payers to differentiate and capture important product and patient-specific information. Unique Level 2 HCPCS codes will allow physicians and other healthcare professionals to report and appropriately treat adverse events. Unique Level 2 HCPCS codes will allow payers to differentiate Hyalgan from Supartz. For all of these reasons, we respectfully request that the HCPCS work group reconsider their preliminary decision to maintain current code J7321 for the two products. FIDIA requests the establishment of two new Level 2 HCPCS codes. HCPCS XXX, hyaluronan or derivative Hyalgan for intra-articular injection 20 milligram dose, and a separate and distinct JXXX, hyaluronan or derivative Supartz for intra-articular injection 25 milligram dose. Thank you, members of the HCPCS work group, for your time and consideration.
Roy Smith.
Good morning. I'm Roy Smith. I work for FIDIA Pharma as an employee, and I oversee our managed care and access areas. I just wanted to point out a few notes from what Carolyn had said, and in support of a separate J-code. From the payer reimbursement end, it's more of a, it's like a two-prong issue, and it's more around the programmatic, where their programs and their systems can't really support the two separate J-codes. And then as that relates to the cost issue around being able to contract with us, and actually a patient safety issue, just in case there is actually ever a recall of one of the products. Because as Carolyn had pointed out before, we are literally, that J-code is 31% of the entire market. So if there was something to happen with one of those products and it relayed back through one of the payers, it would be very difficult to have any recall due to any adverse events. And I actually was going to show the number myself of the market share. And I basically just wanted to support the separate J-code. Thank you.
Thank you. We have another 5-minute speaker. Michael Daly.
First of all, my name is Michael Daly. I am the past medical director of Hyalgan for Sanofi. I have been a consultant for Fidia, and I am the president and CEO of OrthoGenerics that does make a product that competes in the class, but not directly with Hyalgan. I'm also a patient of Hyalgan, and I've received over 36 injections. I can tell you this product is safe and efficacious. I've also had 5 knee replacements. I can't say the same thing about orthopedic surgeons. But with that said, this class of products is the safest class of products that has ever been approved by the FDA. If you look at the MAUD reports for Hyalgan, in 20 years, we are facing now the 20-year anniversary of Hyalgan approval. That's amazing. There's less than 400 MAUD reports on the adverse events reported spontaneously. So to argue that you have to have this for safety distinction is not very valid. Secondly, these products are regulated as devices. Each batch has a unique identifier code on it. The UDI is on every single syringe. You can pull a batch from a recall. You do not need a J-code to distinguish that. Thirdly, there is no substantial evidence to suggest that there's a distinction between the different HAs. I'll say that again. There is no substantial clinical data. And if you go back to 2005, the Cochrane collaboration, that is supported by that. So these products all work the same. They work essentially pharmacologically the same. And even the dosing formulation that has been published by Hyalgan and by Supartz says that the dosing can't really be distinguished. We don't have that ability to tell the difference between a 20 and 25 milligram dose. Finally, there is only one J-code in the entire hyaluronic acid that has decreased its average selling price over the last 10 years 1 to 2%. Only one. That's J7321. And why is that? Because these two products compete for pricing. It has held down that pricing. All the other J-codes have been able to take a 6 to 8% average selling price increase every year because the WAC is not regulated by any of the agencies. So when you elevate the WAC in the AWP, the ASP can be brought up because the ASP is a weighted average across all distribution channels. So therefore, the request for the same J-code is something you visited many times before on behalf of the other product, Supartz. Supartz requested back in 2001 to be in the same J-code. The HCPCS coding group agreed with that. These products were approved prior to 2003, so the Social Security Act of 2003 does not apply, and it is inappropriate. It will increase the cost of products if you separate the J-code, and you will decrease competition. And the reason that private payers, they're not on the formularies, is because, and it's my personal peeve, why do you have to pay a rebate to somebody that acts no value added to the healthcare system. That's why they can't get on the formularies, because you would be paying rebates for both Hyalgan and Supartz. And why would Hyalgan pay to be on a formulary that then Supartz can be on with the same J code? So those are the reasons. I agree with the HCPCS coding decision, and adamantly oppose having separate J codes. Thank you.
Thank you, Dr. Daly. I'd like to address some of your points. With regard to identification of Hyalgan and Supartz, I think from a payer perspective, right now it is very difficult by sharing the J code J7321. We understand that that there are other codes to identify the product, like the NHRIC code, but when we've spoken to different payers, they actually do not include that in their system, and so they don't capture the NHRIC or NDC code. And furthermore, with medical devices, the NHRIC code is actually going away September of next year, September 2018. And so that's, for all those reasons, from a differentiation and identifying which product is which, we do think that it is very important to have separate J codes for these two products. With regard to the pharmacologic and therapeutic differences, while Hyalgan and Supartz are in the same class of products, hyaluronic acid, Visco supplementation, we believe, demonstrated that there are significant differences from the dosing, from the treatment cycle, from the various preclinical and clinical data, to also warrant the fact that they are therapeutically distinct. And so when we look at the criteria that the HCPCS coding had put forth with regard to what makes a product garner or justify having a unique J code, we do believe that Hyalgan does fit these criteria of being therapeutically distinct, operating differently, and having a significant market utilization. Thank you.
Agenda item number 6, application 17.51, request to establish a new level 2 HCPCS code to identify Visco 3. Primary speaker is Mr. Sean Murphy.
Good morning. Thank you for the opportunity to speak this morning. My name is Sean Murphy, and I am an employee of Zimmer Biomet. We are the applicant here for application 17.051. Zimmer Biomet submitted an application with a request to establish a new level 2 HCPCS code to identify hyaluronic acid injectable product with the trade name Visco 3. We suggested that the language for the code be JXXXX hyaluronan or derivative Visco 3 for intra-articular injection per milligram. The HCPCS work group's preliminary coding decision was that J7321, the existing HCPCS code that identifies Hyalgan and Supartz, be modified to add Visco 3 in the descriptor and also identify Visco 3 as of January 1, 2018. And Zimmer Biomet respectfully disagrees with that preliminary decision. We believe that there is a national programmatic need for the establishment of a unique J code distinct from J7321 to identify Visco 3. For similar reasons, as you just heard from the speaker before me, that in the commercial insurance sector, there is a need to separately identify products by J code for the purposes of administering rebate and medical management of Visco 3 and other similar injectables that are commonly paid under the medical benefit of a health plan. A little bit of background on Visco 3. It is indicated for the treatment of pain in osteoarthritis of the knee in patients who failed to respond adequately to conservative non-pharmacologic therapy and simple analgesics. Visco 3, like all products in the class, is administered via intraarticular injection by a healthcare practitioner. Visco 3's dosing is 3 weekly injections of 2.5 milliliters in volume each. Visco 3 acts to supplement the naturally occurring hyaluronic acid in the synovial fluid within the joint capsule of the affected knee to provide cushioning and lubrication to the joint, which has been reduced as a result of the degradation of the joint caused by the osteoarthritis disease state. Visco 3 is chemically equivalent to 2 products on the market today, Supartz and Genvisc 850. To the national programmatic need, we do recognize that there is no need within the Medicare payment system to separately identify these products at this time. This programmatic need is within the commercial insurance sector, which again is something that's resonated from prior speakers as well. Increasingly, commercial health plans are seeking to manage payment and coverage of specialty drugs and other similar products, such as these products that are classified as devices but often paid for as specialty drugs, under the medical benefit of the health plan as opposed to the pharmacy benefit. And they're using mechanisms that they've traditionally employed under the pharmacy benefit, such as rebates, product preferencing, formularies, utilization management tools, and step edits. In a pharmacy benefit transaction, health plans and PBMs are able to identify the drugs using the NDC number, and they're able to utilize these management mechanisms based on NDC or a related number like the NHRIC number or a UPC number. However, many health plans and PBMs have identified that they lack the capability to employ these same mechanisms in a medical benefit transaction on a CMS 1500 or an electronic equivalent with those codes. And therefore, there is a need for unique J codes to separately identify these products in order for these management mechanisms to be employed. When more than one drug is classified under the same HCPCS code, the PBMs and the health plans are not able to uniquely identify the products. And as a result, that may limit access to one or more products because they simply exclude them from coverage or from formulary or put them in a lower level tier coverage from other products that they can separately identify. There are currently 12 products approved by the FDA on the market in the US within the hyaluronic acid Visco supplement class of products, Visco 3 being the 12th product to market. All products within the Visco supplement class are physician-administered injectables, which are most commonly paid for under the medical benefit of a commercial health plan. And similarly, that's why they're paid for under the Part B drug component of the Medicare program. According to a recent industry report, Visco supplements are the second most common class of products with which health plans implement medical benefit drug rebates. And up here on the screen, you can see this is a graph from the recently released Medical Pharmacy Trend Report 2016 that was published by Magellan RX Management in March of this year. The second from the left column at 45% there is Visco supplements, showing that 45% of commercial payers surveyed manage this class under the medical benefit using rebates. Of the 11 products other than Visco 3 in the HA class, as you have already heard here today, all but 2 products are uniquely identified by individual HCPCS codes, save Supartz and Hyalgan, which are classified under the same code, J7321. Many health plans and PBMs that utilize rebating and other forms of medical benefit drug management have excluded Supartz and Hyalgan from coverage because of the inability to uniquely identify the products for administration of such programs. In our conversations pre-market with Visco 3 with those payers and PBMs, they have already informed us that we will have the same fate as a result of not being able to uniquely identify Visco 3 if the coding decision, the preliminary coding decision by the work group stands. In conclusion, I believe Zimmer Biomet maintains that there's a national programmatic need that has been substantiated across the commercial payer sector to separately identify Visco 3 by commercial, in order to properly administer payment and coverage mechanisms that are commonly employed within medical benefit drug categories. I thank you for your time and consideration.
Carolyn Kong.
Carolyn Kong, employee of Pharma US, Chief Business and Development Officer. Pharma USA respectfully disagrees with the HCPCS work group's preliminary decision to include Visco 3 into the same J code J7321 as Hyalgan and Supartz. Visco 3 is pharmacologically and therapeutically different than Hyalgan. Its composition, volume, molecular weight are different. Hyalgan and Visco 3 have different dosing per administration, different volumes per administered injection, with different overall dose administration to the patient per the FDA-approved treatment regimen. As reported in the literature on preclinical and clinical testing, Hyalgan has a lower coefficient of friction, a lower reported adverse event rate, more long-term follow-up data, and cost-effectiveness data, and is the only HA with clinical data compared to NSAIDs in its label. Hyalgan is pharmacologically distinct from the other HAs on the market and is not interchangeable with Visco 3 or Supartz. All of the products in this class each have been given their unique J code, with only Hyalgan and Supartz sharing a code. There are 9 unique codes to describe these different products. Assigning Visco 3 to the same code as Hyalgan and Supartz is not consistent with CMS current policy. By sharing the same J code as Hyalgan and Supartz, patients will have limited access to Medicare Advantage reimbursement as well as limited access to private payer plans, as Sean has described. Payers will not be able to separately identify these 3 HA products on their claim forms. By sharing the same J code as Hyalgan and Supartz, it will be difficult to track adverse events and properly characterize each of their safety profiles. Unique Level 2 HCPCS codes allow physicians and other healthcare professionals to report and appropriately treat adverse events. From an operational standpoint, by assigning a new code, payers will be able to differentiate and capture important product and patient-specific information, eliminating a programmatic concern to their systems. So in conclusion, we respectfully disagree with the HCPCS work group's preliminary decision to include Visco 3 in the same J code as Hyalgan and Supartz. Thank you.
Michael Daly.
Man, getting up and down after 5 knee replacements is tough. Anyway, my name is Michael Daly, and as of 10 minutes ago, I was still the president and CEO of OrthoGenerics. I haven't been fired yet, but I haven't received a tweet to counter that. We agree to the HCPCS coding group's decision not to create a new J code. We do not agree that it needs to be modified to accommodate Visco 3 because all it is, it was a PMA supplement to Supartz, okay, that changed the directions of use to 3 injections. So essentially, it's smoke and mirrors because this is Supartz FX. This is Visco 3. There is no difference. It is coming off the same manufacturing site. It is the same composition. It is the same dosage form. It is the same in directions for use, except 3 weekly injections. And in the Supartz directions for use, it says some patients benefit from 3 injections. So therefore, in the marketplace, these products are used 3 to 5. When you look at the utilization data, they're actually 4. So half the patients tend to get 3, half of them get 5. This is just much more substantial data with approval through the FDA as a PMA supplement. Since the PMA was approved in 2001, again, the 2003 Social Security Act does not apply. And if you grant a supplement a unique J code, you have opened up Pandora's box. That means every time I change my labeling through a supplement, and on the average, each of these products has somewhere between 20 and 30 different supplements during their lifetime, you might be faced with as many as 70 to 1,000 different J-code applications to try to change the reimbursement code. This is all a play to get higher reimbursement. The reimbursement for this J-code is the lowest amongst the entire class, and again, it's lowest because there's competition. So therefore, we also submit that the same company that manufactures manufactures this product is also the one that changed their branded name without getting appropriate HCPCS coding, and that Supartz FX is actually not in the brand in the descriptor at all. So, with that said, I would suggest that the working group fundamentally make it clear that supplements are not going to receive separate J-codes just simply because it's 3 injections versus 5 when the first one is 3 to 5. Thank you.
Thank you for the comments from both of the 5-minute speakers there. I'd just like to respond for a moment to the latter speaker and clarify that our request is in no way based on the FDA approval or any supplement or primary approval by the FDA. The basis for our request is the national programmatic need that is set forth by commercial payers and the PBMs that work on their behalf in order to separately identify products that are commercially available for the purposes of medical benefit drug rebate and management mechanisms. Thank you.
So yes, I have a question. I'm a little confused. Medicaid is required to report NDCs on all J codes, and the OIG has been auditing states for this. And so we determine rebates and individual drugs by NDCs. Why wouldn't that continue to be the case here?
So in the case of Medicaid, this product category in particular is excluded from the Medicaid drug rebate program because of its FDA approval as a medical device. None of the products in this class are part of that program, and therefore our claim for national programmatic need is not based on Medicaid's adjudication of any claims here, solely for commercial health plans and the Medicare Advantage sector. Thank you again.
Agenda item number 7, application 17.29, request to establish a new level 2 HCPCS code to identify afstiller. There are no speakers for this item. Are there any questions or comments? Agenda item number 8, application 17.30, request to establish a new level 2 HCPCS code to identify Covaltree. There are no speakers for this item. Are there any questions or comments? Agenda item number 9, application 17.1, request to establish a new level 2 HCPCS code to identify Inflectra. There are no speakers for this product. Are there any questions or concerns? Agenda item number 10, application 17.3, request to establish a new level 2 HCPCS code to identify Spinraza. There are no speakers for this item. Are there any questions or comments? Agenda item number 11, application 17.49, request to establish 2 level 2 HCPCS codes to identify Astero. There are no speakers for this item. Are there any questions or comments? Agenda item number 12, application number 17.62, repeat request for a new level 2 HCPCS code to identify Zingo. There are no speakers for this item. Are there any questions or comments? Okay. Our last agenda item of today, agenda item number 13, application number 17.56, request to establish a new level 2 HCPCS code to identify Parsabiv, and application number 17.57, request to establish a new level 2 HCPCS code to identify Sensipar. Our primary speaker is Mrs. Holly Owings.
Hi, good morning, and thank you for the opportunity to speak with you today. I'm Holly Owens. I am an employee of Amgen, Inc., the applicant for both of these products. I serve as the Director of U.S. Health Policy and Reimbursement. Again, thank you for the opportunity. I am here. We have requested 2 unique Level 2 HCPCS codes for Parsabiv and Sensipar. Parsabiv, etelcalcetide, is an intravenous synthetic peptide calcimimetic agent that allosoterically modulates the calcium-sensing receptor for the treatment of secondary hyperparathyroidism in adult chronic kidney disease patients who are on hemodialysis. Parsabiv was FDA approved on February 7, 2017. Additionally, we are requesting permanent and temporary HCPCS codes for Sensipar, which is cinacalcet, is an oral daily calcium-sensing receptor agonist calcimimetic agent that is indicated for the treatment of secondary hyperparathyroidism in adult CKD patients on dialysis. Secondary hyperparathyroidism develops in many patients with end-stage renal disease, and it occurs when the parathyroid gland secretes excessive amounts of parathyroid hormone as part of the response to the decreased renal function and impaired mineral metabolism. Again, Amgen applied for permanent Level 2 HCPCS J codes for both Parsabiv and Sensipar for 2018, excuse me, but also requested temporary Level 2 HCPCS Q codes for both products in 2017. The requesters, again, we requested both a permanent J code and temporary Q code for both products, and CMS's preliminary decision is to grant permanent Level 2 HCPCS J codes for both products, but no indication on temporary HCPCS codes for both. And I will explain to you why we think there is a program operating need for temporary Q codes in the interim. First of all, Amgen strongly supports the decision to grant permanent Level 2 HCPCS J codes for both Parsabiv and Sensipar, including the code descriptors and revised units. Permanent Level 2 HCPCS codes are essential for processing Part B medical benefit drug claims in a timely and consistent manner. But importantly, and what I'm going to spend the focus of my time discussing today, is that HCPCS codes are necessary to implement a new policy that was finalized by CMS in 2015 that is called the Transitional Drug Add-on Payment Adjustment, which is going to be paid as part of the ESRD prospective payment system. And again, this was finalized in calendar year 2015, but has yet to be implemented. The temporary drug add-on payment adjustment, again, it was used or was finalized as a mechanism to recognize new therapies that qualify for additional payment in the ESRD PPS. The end-stage renal disease prospective payment system was implemented in 2011 and was intended to include all items and services as part of one bundled payment. What the ESRD PPS was lacking was any mechanism to recognize new treatments and how to incorporate the payments within the system. Therefore, CMS finalized this, what's called TDAPA, in 2015 for qualifying new therapies that have no valuation in the ESRD PPS payment. Additionally, CMS recognized that, that this TDAPA is appropriate to pay for calcimimetic therapies. Again, Sensipar is an oral calcimimetic agent that was approved in 2004 and has been paid under the Medicare Part D benefit since the program's inception. But CMS had indicated that with the FDA approval of an IV calcimimetic, the oral calcimimetic Sensipar would no longer be oral only and therefore eligible for payment within the ESRD PPS, but recognized there were no dollars assigned in the ESRD PPS for calcimimetic agents. So the finalized policy specifies that both the oral Sensipar and IV Parsabiv would be eligible for this TDAPA payment for a minimum of 2 years, and it would be upon the FDA approval of the IV calcimimetic and assignment of HCPCS coding. So again, because the permanent Level 2 HCPCS J codes will not be effective until January 1 of 2018, we believe there is a programmatic need for the temporary Q codes to be established and effective in 2017 in order to implement this new payment policy. Otherwise, there is no coding option for use in the predominant setting where particularly Parsabiv will be used until this policy is finalized. So again, because of this ESRD PPS, this is a unique situation, we believe, that merits these temporary codes in the interim. There is obviously substantial precedent of CMS issuing temporary Q codes for new drugs and biologics when the operating needs exist. Again, just for this cycle alone, when CMS issued the preliminary decision, or they issued the list of temporary codes that will be effective for July 1 of 2017, there were 3 products that were actually being deliberated today as part of the permanent process that we've heard from currently. And these codes that CMS had established would be effective for July 1 of 2017. We believe that there is precedent and therefore need for this similar occurrence to happen for both Parsabiv and Sensipar. Again, we think this TDAPA represents a significant operating need because this coding is necessary for this policy to be implemented. So without a temporary code, there will be no coding option or payment recognition for a newly FDA-approved product for almost a full calendar year. And let me just pause a minute for address the unclassified J-code that is often used, and I know was discussed previously by other applicants, as a mechanism in the interim before codes are effective. J3490 will not be appropriate for Parsabiv in the interim because the ESRD PPS precludes the reimbursement recognition for any HCPCS codes that are not reported using a special modifier. And this modifier is used only for products that are not renal related. In other words, any products that are used within the dialysis that are not related to ESRD care, they have the ability to get separate reimbursement. But unfortunately, well, not unfortunately, calcimimetic agents are clearly renal related. So unfortunately, the AY modifier that is used for those products would not be appropriate in this setting. So again, there will be no coding option with the use of J3490. And that is our major concern and why we believe that temporary codes are warranted to be effective in 2017. So that concludes my comments. Thank you very much. Are there any questions? Are there no comments? There's no other. Okay. So are there any questions? Okay. Thank you very much.
Thank you. We have concluded our agenda for today. We'd like to thank everyone for all of their excellent and thought-provoking discussions and for taking time out of all of your busy schedules to appear here in person to share with us all your valuable input. For those of you who will be joining us tomorrow, we will see you tomorrow. And for those that may return next year, we'll see you next year. Enjoy your day.